Good evening, everybody.
Good evening.
Thank you so much for coming in this weather today and joining us to learn about the unit that we built up in the last 1 year at Berkeley Medical Center. And I'm sure this unit is going to help the families in this community. It's called NICU. What it means is it's Neonatal Intensive Care. As Dr. Brown mentioned that I graduated in India. My passion for neonatology took me to England, and I trained in fellowship for neonatology in Canada after being trained in England, and also then I moved from Canada to the States to complete my fellowship as well as my training. I've been in this field since 1991, and I've been learning and talking neonatology since then. I worked in various units and finally decided that at this phase of my life, I think I need to give back to the community. I was looking for a place where I would be able to give it my wholesome attention to it. After seeing the enthusiasm and of the entire team of administrators, as well as the pediatricians and obstetricians at the Berkeley Medical Center, I thought that this was the right place for me to set up a unit and build this unit up here for the community. And I'm sure it is going to, and I think it's already showing that it is supporting the community. So let's talk about the unit. What is neonatal intensive care? Well, the National Center of Health Statistics defines a NICU as a hospital facility or unit that is staffed and equipped to provide continuous mechanical ventilator support for more than 24 hours. And it's not only the ventilatory support that the baby requires, the newborn requires, but also the nutrition and also the emotional support that the baby gets from the NICU. And what does the NICU do? The NICU facilitates a physiological transition to the extrauterine life. And by that I mean that when the baby is born prematurely or at term, for what the baby really requires the same environment as what the baby requires within the mother, and thus that's what we are trying to achieve in a NICU. Respiratory care and nutrition after birth is critical to support the transition. Intervention should be based on the right balance between supporting transition and avoiding injury. I mean, especially injury, because these babies are very fragile, and we really need to take care of these babies very delicately. Up here and between the two hospitals that we serve up here in this county is Berkeley Medical Center and Jefferson Medical Center. There are 9 obstetricians at BMC and 4 at JMC. And the births in the last year at BMC were 955 and at JMC were 258. And it's continuously increasing as the population in this county is increasing. So we expect more obstetricians coming and joining the group because of the population increase, as well as the births that we're expecting in the next few coming years. In 2012 to 13, there have been an average of 12 to 20 per year of maternal transfers for the lack of a NICU at BMC. In 2014, that has dropped down significantly to less than 7 to 8 up to date. That goes to show that our presence up here has shown a lot of difference, and we are already started serving the community up here. So what are the neonatal problems that are taken care of in a NICU? Well, the NICU really takes care of babies that are born either prematurely or even at term, because any baby that is born, they too tend to have problems of some sort or the other. If they have, every mother wants a healthy child, but there are sometimes they come up with some issues that we need to take care of. And mostly we start with respiratory care, respiratory issues. Most likely when they are prematurely, their lungs are immature, they need support to breathe, and that's what we support them with. There are babies that are born with, when they pass meconium, that is the stool that comes out when the baby is stretched in utero, and they may sometimes aspirate too. And sometimes when they're just born by cesarean section, they may tend to have, or they're born rapidly, they may have something called as TTN, that is transient tachypnea of newborn. Sometimes there's about less than 0.5% of babies that tend to have normally have a leak in their lungs because of some reason or the other, and we have to take care of that. That's called pneumothorax. Babies can be are more prone for infection if mothers have breastfed for a prolonged period of time, and if they have an infection, viral infection or so. So we need to take care of that as well. Hypoglycemia, that is low blood sugar in babies, that's also known. Drug withdrawal. Our community up here, we know that there is a lot of drug withdrawal issues up here, and that's why these babies are affected with drugs, and they do withdraw, and we need to take care of that. And in a very nice manner, so that they do not really start having other problems with it. Jaundice, that is also important. It could be physiological, but sometimes it's pathological too, and it's exaggerated, and that we need to take care of that too. There are babies that are not growing in utero well, and those are babies that are with IUGR, and babies with very low birth weight babies. There are cardiac and surgical issues too. Babies can be born with some hole in the heart. There could be a problem with the baby, or with surgical issues that require attention. We stabilize those babies, and we get a diagnosis, and we transfer them to the appropriate facility so they get their appropriate care. In the last 1 year, I've had at least several cases where we had a cardiac disease, we've had gastrointestinal problems, which we took care of. We diagnosed it, and then we transferred them to their appropriate place. Previously, when the NICU wasn't available up here, they used to go from one hospital to the other and then bounce up to the place where they would really leave to get their treatment. So at least now we know that we can diagnose it, and then they go right away to the place they can get the right treatment. And comparing outborn to inborn infants with respiratory problems showed that the inborn infants had significant and lower ventilatory and oxygen requirements and shorter duration of stay and a better outcome. What's really important is the better outcome. So what this really is telling you is that if a baby is born and has issues at birth, if it's taken care of in the same hospital that it was born, rather than being bounced from one hospital to the other, the outcome is better if it was taken care of at the same hospital, rather than being transferred from one hospital to the other. So that's the reason we thought, and the obstetricians and the pediatricians thought, that this place needs a NICU. And that's why for the last 1 year, we've been really striving hard to build this unit up for this community. And I'm sure it's going to be building all the more and bringing good results to this community. In 2013, we had about 32 transfers of newborns from this hospital at Berkeley Medical Center. And if you go to see, if you go to see, most of them all could have been taken care of babies in this place. They all were within the reach of what we've been doing for the last 1 year. And we haven't, and I feel bad that they have to be transferred, but I think now that we are here, we'll take care of them. In the last 1 year that we've been here and taking care of babies, we've had only 10 transfers. And those transfers, that's a reduction of 70%. And the transfers that really took place were basically the ones that needed cardiac attention or surgical attention. Or they were way beyond our reach to take care of babies in this facility. There are levels of NICUs designated by the American Board of Pediatrics or the American Academy of Pediatrics. There are 3 levels: level 1, level 2, and level 3. Level 1 is basically a hospital that provides services for uncomplicated and newborn patients. So if any baby is born and is fine, they'll just leave the baby there, which we were and we are still doing the same thing. What is level 2? Level 2 is a larger urban or suburban hospital at which majority of deliveries occur. And because they have a highly trained staff and modern equipment, those facilities are capable of treating most premature complications. So this is what we are at the moment. We have built this unit, we have all the equipment, and we really are having the capability of treating and managing most of the complications on the unit with these babies. And what is level 3? Level 3 is basically a capabilities what in level 2 can do, plus they have the surgical and cardiac facilities that they can take care of, which we then transfer them to there so that they can take care. They have the other subspecialties available too. So what are we really doing in a NICU? In NICU we really are trying to, the transition of the newborn starts really, how do we take care of these babies? It's basically we're trying to manage the transition from extrauterine to in utero life. And the transition really starts prenatally with the care of the obstetricians, like Dr. Brown, and high-risk consultants with perinatologists. Those are the high-risk patients that they take care of. They monitor regularly with fetal ultrasounds and given antenatal steroids. That helps the baby's lungs to grow and cope up with extrauterine life if they're born prematurely. Antenatally, a discussion with the neonatologist and planned deliveries of these high-risk neonates is of prime importance for the outcome of these babies. So if a mom comes in at say 26 weeks or say 29 weeks, the discussion that goes on between the obstetrician and the neonatologist really, and then we can plan them when the delivery needs to take place or where it needs to be taken care of, then we can really we see that the outcome is far more better. And the babies do far more better when it is planned to that extent. So what do the neonates, that is the preterm or term babies, need? Well, they really require very little support. They really require a lot of TLC, tender loving care. But they also require the environment that the baby is growing in utero. We have to mimic the same in ex utero. So what it requires is maintaining temperature, maintaining respiration and a respiratory support, nutrition, that's really prime importance. They may need medications, radiology investigations if they are sick, and we need to figure that out, as well as laboratory investigations that the baby needs to be monitored and taken care of. And to facilitate the transition, what we need is trained nursing staff. We need a physician who's been taken care of or been trained in newborn care and their problems and their diseases. We need a neonatal nurse practitioner who's been trained extensively in the field of neonatology. And we need trained neonatal registered nurses as well. We need trained respiratory therapists who can take and manage the baby's respiratory status, as well as the equipment that comes along with it. And we need trained pharmacy staff for newborn needs, and trained radiology and laboratory techs, as well as a full blood bank, which if the baby requires blood, we need that as well. We have trained lactation nurses and consultants for their support in supporting the mothers for lactation, for breastfeeding, as well as when they can express their breasts out for feeding the babies if they are not being able to bottle feed or breastfeed. We need supportive subspecialty staff, and we need occupational therapists and physical therapists for comfort care of the babies and positioning the babies so that they do not get any contractures or any other issues. If they have any issues like palsy or fractures, they can splint them and they can take care of them. So what are we going to do at BMC, in NICU? And what will we provide? Are we going to provide everything? I think we can. I will show you that. So we have trained registered nurses, and that is 24 hours. Trained nurses are available on the unit. And with the critical ill babies, we have one-to-one nurse. That means if a baby is critically ill, the sole responsibility of the nurse during her shift is going to be taking care of that sick baby. And if there are some other babies that are more stable, we do not go beyond 1:3, 1:2, or 1:3. They are trained in neonatal resuscitation, that is NRP trained, so that they can, whenever there is an issue, they sure can resuscitate a baby or give the basic necessities till the physicians come in. They are trained in a stable course. A stable course is basically stabilizing a newborn baby whenever the baby is born sick. So there are so many aspects when a baby is born sick that stable course goes through each and every edition of what the baby really requires, and are trained in that. They attend high-risk deliveries and cesarean sections, and they are very efficient in starting IVs and monitoring central lines. When a baby is born and is very sick and needs to be monitored centrally, we put lines through the umbilical vessels. That is, we put it through with an umbilical artery or a vein, and those are centrally monitored. If a baby has a leak in the lung and the air comes out, it's called a pneumothorax. We put chest tubes, and they are very efficient to even monitor that. They are very good in nutritional support for tube feeding. If a baby cannot feed, like if you have a 30-weeker we have one on the unit, they can't feed. They can't bottle feed, and that's why we tube feed them, and they're very efficient in doing that. And once they are transitioning from tube feeds to bottle feed, they are very efficient in doing that. They know which nipple is good for the baby. They know it's a slow-flowing nipple or it's a fast-flowing nipple, which baby suits the best. They know it. And they also support breastfeeding. They know all about neonatal monitors, and and they always consistently look at the monitors to see whether they are the babies are stable. That's just showing you a nurse taking care of one of our babies. That's one of the smallest babies in the unit, and it's a one-to-one care. And what's next? After the nursing comes what does the baby require? It's temperature. So temperature regulation is very important. We take care of the baby's temperature control right from the delivery room, right till the baby and in the unit. And we maintain the temperature in a thermoneutral environment. what that means is the baby requires that temperature so that the baby doesn't fall sick, doesn't go hot, doesn't go cold, or doesn't go too hot. So we have warmer beds in the delivery room. We have transport incubators. So when a baby is being transported from the delivery room to the NICU, they are transported in a transport incubator, so they maintain the temperature and they do not get cold during the transport. We have an omni bed. What omni bed really means is it's a bed that can convert from a warmer to an isolate to a crib. And that's the latest thing in the NICU, so that the baby doesn't get shifted from from the warmer to an isolate to a crib. It's all in one, and we'll show you that too. So that's a warmer bed that is you see in a delivery room, and it has a lot of facilities that it can weigh the baby, it can monitor the baby's blood heart rate, oxygen, and also it has a small little dial that if the baby requires anything like a pressure or CPAP, continuous positive pressure, that you can deliver it with that. That's your transport incubator, and it maintains the temperature all during the transport from the delivery room to the NICU. And that's where the NICU treatment room is. As soon as the baby comes into the NICU, the baby is put into and treated and stabilized in this area. And that's a typical room for a baby, and that's the omni bed. And that is where the hood can go up. When it is up, it turns out it's a warmer. And when it is down, it turns as an isolate. And when it is up again and the heater is off, it is a crib. So it's all called as an omni bed, and you can do everything on that. I call that a Cadillac for the baby. What's next? It's a respiratory support, and that's what the baby requires as soon as the baby is born. The baby really requires respirations to breathe and air to survive. I mean, we all need air to survive, and the baby needs to breathe comfortably, and that's what we're trained to do and try to achieve. And we have trained neonatal care, respiratory staff that are trained in neonatal care and neonatal equipment. They are all NRPs, that is NRPs certified. They attend high-risk deliveries and cesarean sections. They are expert in the neonatal equipment, and the neonatal equipment are nasal cannula, high-flow nasal cannula, a continuous positive air pressure, that is CPAP, like even adults use it these days, but even the babies require that. With CPAP, CPAP is basically CPAP with where the babies can get some breaths along with it. And ventilators are basically mechanical. When you put a tube down the baby's throat, the babies are on a ventilator. And these are all depending upon the baby's requirements and the baby, how and what respiratory distress the baby is, we give them all that accordingly. And that's our respiratory staff. You see that the baby is ventilated, and that's a ventilator. Along the side is a CPAP and CPAP machine. And once the baby is off the ventilator, goes on to the CPAP, CPAP machine. And then we wean them off slowly off that to a high-flow nasal cannula or room air. So respiratory and cardiac care, they all are trained neonatal respiratory staff. They all are 24 hour on call. So whenever their baby is on any respiratory support, we have a 24-hour call, a respiratory therapist who is on there, comes in very regularly and checks on the baby, sees his requirement, and does everything that the baby requires on respiratory support. He checks the blood gas. If we order blood gases, the baby will check the blood gas, and the unit is available on the unit. They also do the echocardiogram if the baby is having any arrhythmias, heart rate variability. He will do that. he or she. We have echo techs, 24 hours on call, and whenever there is an issue that the baby is having a cardiac issue, or we think that we suspect the baby has a cardiac problem, we call them from home, or if they are in house, we call them to get an echo. And we then do telemedicine. In the telemedicine, what we do is basically we transmit the echo or the EKG to Morgantown, and they read it and give us the results right away. What we plan to do also is to do video EEG and our eye exam for the babies in the near coming future. What else do we do? We do nutrition monitoring and glucose monitoring. That is very important for babies really when they're born prematurely, or if they are intrauterine growth retarded. That is what IUGR is. Or they are large for gestation age. They are babies that are born with 10 pounds and 11 pounds too. And I'll show you that. We have those. And there are babies born to mothers who are diabetic, infants of diabetic mothers. All these babies tend to have problems with their sugar, and we try and monitor them. And all of them have a protocol for each group. So we have all that there, and they're monitored very strictly every 2 hours, 1 hour. We make sure that the babies the sugars don't fall, because the baby's brain is really dependent upon glucose. That's an IUGR. That is an intrauterine growth retarded. This baby was a 30-weeker and was born with 2.5 pounds. Was really small, and we took care of this baby, had respiratory issues. You can see the CPAP on the baby. We also had intubated the baby and was on a ventilator for a few hours. The lungs were mature, and the baby did very well. We extubated the baby and was on CPAP for a few days, and then today the baby is on room air. And the baby is growing, feeding through tube feeds. And that's a baby with IUGR. That's our 10.5 pound, nearly 11 pound baby. Even this baby came in and had issues with respirations and glucose. The baby, we monitored that, and within 10 days the baby went home. So glucose nutrition for premature and term babies is very essential. Once the baby is sick and is not tolerating feeds, and we cannot feed the baby like the IUGR baby, we put the baby on total parental nutrition. And what that is it is a nutrition that gives the baby protein, glucose, and lipids. So they get the appropriate calories to grow and overcome their problems. We have trained pharmacy staff to prepare the TPN. We monitor the electrolytes and adjust the TPN accordingly. We monitor calorie intake. We have, like I mentioned before, we have a lactation consultant who then advises the mother to pump, and whatever breast milk we get, we store it in the individual baby's freezer, and we can always give them by tube feeds. There's a lactation room present on the unit where the mother can go in privacy and pump her breast. And each a baby has an individual refrigerator for each baby to store their breast milk. And also, once it's frozen, the milk is warmed up in a milk warmer, and that is for individual babies available by the bedside. That's the lactation room where the mother can go in and breast pump and store the milk by the bedside freezer. Pharmacy. Well, what else does the baby need? Well, the baby is sick, needs antibiotics, needs cardiac medications, may need medication, TPN, like I said, in nutrition. And it's the pharmacy that does all that. We have a full functional pharmacy for 24 hours. We have a neonatal pharmacist who's and who provides us with neonatal medications as well as neonatal doses. I mean, we can't give adult doses to these little ones, so we really have to give them the appropriate dose. And the doses they're monitored, and we monitor those blood levels of the medications as well. And we support them with total parental nutrition. That's one of their functions, duties too. And that's our pharmacy staff, and they're very happy and they're always available to help us out. Be it middle of the night or be it anytime, they are always available, 24 hours. What else do we need? We need a laboratory that can really do the investigations that we need. Like when a baby is born, like I said, they need some blood work for if there's an infection. We need to know that. We send them blood cultures, we send them blood glucose, we send them all kinds of things. And what they tend to do is they assess the baby, they get the results to us as soon as possible. If all tests are, most of the tests are done on the hospital, but if they're not, they've been sent out, and the results are expedited too. There's a full-time blood bank, 24 hours available to us, and the blood products, all possible blood products are available. And they're all in the neonatal sizes. We don't give an adult bag to a baby. These babies require just packed red blood cells. That means only red blood cells. We don't give a whole blood to these babies. We just give them the red blood cells. And that's what is available. And they're in small aliquots. So it's not a full bag like a 500 ml. The babies require the maximum is about 30 cc's or 20 cc's or even 15 cc's. If a baby is as small as that little one we had and we had to transfuse, we did not need more than 15 cc's. So they give us those small little aliquots. We also give platelets as well as plasma. What else do we need? We need radiology to investigate whether the babies are, what their chest lungs look, what the abdomen is. So we have a whole functional, 24-hour functional radiology unit. And we do have a portable X-ray machine, like you saw in the last. That's a portable X-ray machine where the radio tech comes and it takes the X-ray for us, and they are transmitted wirelessly to the PACS system where we can see the X-ray right away. It doesn't have to go and get a film, so it's basically all done electronically now. We have portable ultrasound machines. If you need to see the baby's head scan, do a head scan or an abdominal scan, we can do that. We have MRI and a CT scan capabilities, as well as Bayesian studies. If a baby is not tolerating feeds, we can do Bayesian studies to find out whether the baby has any issues with the gut. What else do we need? We need the babies to grow and be physically well. So we have occupational and physical therapists. And what we do with them, what do they do with the babies? They're trained neonatal OTPD staff for the neonates. They provide neonatal comfort care for premature babies. With drug withdrawal, basically with drug withdrawal, what these babies really need a lot of comfort care and comfort positioning, so that they can, one, get weaned off from the medication, or not even avoid medication. They do neonatal massage. They're small little masseuse for them. You know, they get a spa treatment in our unit. They do splinting and fractures, splinting for fractures, and also for if there are any palsies, like if it's been a difficult delivery, the baby tends to have some palsy of the hand because the nerves are being stretched. Then these ladies go and splint them and take care of them. They also do feeding interventions and find out which is the best way to feed these babies, which position is good for these babies to feed, and also development care as for inpatient as well as outpatient. And they provide follow-up as outpatient as well. We have an isolation room. If a baby goes out, neonatology is basically between the day the baby is born to 28 days. So if a baby is born goes home and within 28 days has any issues with infection or any other issues, can still be admitted into our unit and will be kept in an isolation unit and can be taken care of. If the baby has, say, MRSA, then the baby is in that unit and is taken all possible precautions so that the infection is not passed on to the other patients. When a baby is jaundiced, the way to treat these babies is by giving phototherapy, and each Omni bed, the Omni bed that I said looks like a Cadillac, has a phototherapy machine that will basically reduce the baby's jaundice. And we have different types of facilities to treat the jaundice. We have the light, we have a bed, so where the baby can just lie on the bed and get exposed to it, to the light. And we also have a blanket, so the baby is wrapped around it and gets all the effect of the phototherapy. And with the blanket, the plus point is the mother can breastfeed as well. These babies here are so small that they really need to be in an isolate for temperature control and all that. So avoid infection. So they are in there, and we use these lights to reduce their jaundice. And that's a typical bed that we normally see. You see a nurse, but that's the Omni bed. That's the hood is up. You have a freezer up here where the milk is stored. The baby's milk warmer is up there. You have their own pumps up here. They are fully monitored all the time, 24 hours, and that's a very typical bed in the unit. And you'll see all this when you tour the unit. And what's the latest nowadays is everything is wireless, right? You can see Skyping, FaceTime, everything. And we have that capability as well. So this really with the NIC view, this really enables the parents to view their baby from the comfort of their home. So if a mom is discharged from home and wants to view the baby, well, she can log in on a computer and watch the baby there and feel peace of mind and go to bed. What we typically do on rounds is we have a multidisciplinary rounds, so that what happens is, we have the nurses with us, we have the respiratory therapists, we have the pharmacy, we have the medical student, and we have the NICU director. So we all together round daily with babies, and each problem is scrutinized, and we take appropriate decisions on it. And we also include parents on rounds, and we try and give them as much information as they need, and answer all their questions, what they need, what they are worried about. There's 24-hour coverage by the neonatologist and the neonatal nurse practitioner. So if there is a problem, there's always one of us available to solve those problems for the baby. The babies are monitored centrally. That's a workstation. And once the rounds are over, everybody comes up here, does their rounds, and they put in the orders, and all the babies are basically monitored on centrally. And at discharge, all the questions are answered. We tell the mothers, the parents, what are the follow-ups they need to go to, and we make sure that their appointments are made, as well as we give them all the discharge summary, and we make sure that all questions are answered, and we make sure that they are comfortable taking the baby home. We also have social services. We try and make sure that every baby, if requires any social services, we also get them involved so that we make sure that the home is safe for the baby to go. We have volunteer support who makes us lovely wall hangings. And they also have made a lot of lovely things for the isolates. That is something very nice that they made it themselves. Sometimes the smallest things bring the greatest joy. That was awesome. I thought I had to put that on one of my slides. That's our happy and proud staff. They're really happy to work in the unit, and they want to make sure that they want to grow. And that's our NICU director, and she makes sure that all the policies and all the nursing staff are trained and they are up to their competencies, and she makes sure that everybody is accountable for whatever they're doing. That's one of our baby NICU graduates that we're more than happy to send them home. Just wanted to show you what our old unit was. And that was our old unit, which we were there for the last 1 year. And we really grew from that unit to this unit.